Um, it's a pleasure again to welcome you all to another webinar of the SSBMT. These are weekly webinars that we host one of distinguished speakers from different parts of the world, speaking about various topics. So tonight, our webinar is sponsored by Biologics, and we're happy to have Dr. Austin Kulasikararaj, who is a consultant hematologist working at King's College Hospital and King's College London, UK. He also leads at the King's National Pnh service. Dr. Austin, he's expert in PNH and bone marrow failure syndromes. He is actually a member of the European Society of Blood and Marrow Transplantation Severe Aplastic Anemia Working Party. So tonight he will talk about PNH and management, how I treat PNH. So the floor is yours, Dr. Austin, please.
Okay, thank you. That's very kind. Thank you for firstly for the kind introduction, and also for asking me to speak on the topic of PNH. I'll try to get my screen shared. Give me 1 second. Apologies. Yeah. Yeah, got that. Yeah. So thank you once again, and thank you for Biologics for sponsoring this, and also thank you for SSBMT webinar series as well. Before I begin, I know it is Ramadan season soon for you, so if I forget, I'll sort of wish you even at the outset for a happy Ramadan and stay safe during these difficult times. So what I'll try to do in the next 40-45 minutes is try to take you through this fascinating and intriguing disease of PNH, and try to divide my talk into diagnosis of PNH and also treatment of PNH, because I wouldn't have thought when I started doing PNH that we would have a treatment for PNH, leave alone number of different drugs which are going through successful phase 1, phase 2, phase 3 clinical trials, and some potentially due to be approved soon as well. So because it's a rare disease, it's always interesting to take through a couple of case histories, because that puts things into spectrum and also identifies what is the need for in this group of conditions. So this is a gentleman I saw probably a couple of years back, a 26-year-old male, previously extremely fit and well. He presents to the accident and emergency with a very short history of headache, palpitations, and dark urine. Interestingly, he's had a climbing holiday to French Alps very recently prior to this. Before people ask, this is prior to the COVID world. And he also visited Vietnam a couple of months before the presentation. So he subsequently has a blood count which shows that he's grossly anemic at a hemoglobin of 69 with an appropriate retic count and an LDH elevated as indicated. And blood film shows spherocytosis and polychromasia. We do a direct antiglobulin test, and he has got a barn door positive autoimmune positive direct antiglobulin test with both IgG and C3d, and this is a pan-reactive antibody. Interestingly, he tells me because for some reason he missed all his childhood vaccinations, and he says 12 days prior to presentation with this attendance to accident and emergency, he says he had vaccination against DPT, PCV, and MMR. So this is somebody who's presented with a hemolytic process, i.e. hemolytic anemia, and the question is, how would you investigate this in this context? And I know this is a very simplistic view of it, but this is sort of a bread and butter for us as hematologists, which we do regularly. So we know we need to rule out bleeding. And if the data is positive, we are trying to look at autoimmune causes of hemolytic anemia and separating them into warm or cold. But if the direct antiglobulin test is negative, then you go on to look at the morphology, and that can help us to differentiate a number of different conditions, whether it's enzyme defects, membrane defects, or parasitic infections as well. But still, when you do not have the answers, when your direct antiglobulin test is negative and there is no morphological structural abnormalities, then you would want to do a flow cytometry for ascertaining whether this patient has got PNH or not. Secondly, I again want to touch upon another patient who also presented around late 2019, I should say, with this presentation. So he's somebody who's got known sarcoid, biopsy-proven sarcoid granuloma, presents with a typical involvement, and also has got liver and lung involvement with his sarcoid. He responds extremely well to steroids and azathioprine, and he is under a different rheumatologist and hematologist, and they look at him and he has a persistently elevated LDH with the normal blood counts. So don't ask me why they did an LDH, but his LDH was done and it was persistently elevated. And as would happen, he gets on to have workup for lymphoma. He has CT, PET scan. He also had a biopsy of one of the lymph nodes, which was not PET positive, but they wanted to make sure in view of his age, we don't want to miss anything. All his full viral screen was negative. And then slowly he starts to develop a mild thrombocytopenia and worsening LFTs. And because his LFTs were getting worse, they start to think whether it's sarcoid in his liver and start to do an ultrasound of the liver, which shows a portal vein thrombosis. And immediately they do a flow cytometry and find that he's got a large PNH flow. So the question in this gentleman is, it is a disease which can manifest in a number of different ways to a number of different specialists, even to hematologists, and the patients can be with us for a number of period of time before we start thinking that could this be due to an underlying PNH. So the disease is still extremely rare. The incidence is less than 1 per million. Thankfully, the prevalence is high because the survival of these group of patients is getting better and better. And this is the spectrum of manifestation of PNH, as you are very well aware of, with hemolysis, thromboembolism, and variable cytopenia. So in some ways, this helps us to differentiate or delineate into different spectrums of PNH phenotype, i.e., is it hemolytic, is it thrombotic, or does it have a significant component of an underlying bone marrow failure, be it aplastic anemia or myelodysplastic syndrome. So what is PNH? We know that there are normal blood cells have got GPI anchors on the surface of the cell membrane, and then complement regulatory proteins attached to the surface of the GPI anchor. And this GPI anchor is encoded by a gene called PgA. And in PNH, you get an acquired somatic mutation in the hemopoietic stem cells in this PgA gene, which thereby leads to lack of synthesis of GPI anchor proteins, and subsequently the GPI anchor proteins is not bound to the surface protein, and that is the phenotype and genotype of PNH. And what happens? Because we know that we're sitting here or listening to this, if we produce about 2 million red cells every second. So this is a massive churning over. So if you have these red cells being protected by the complement regulatory proteins on the surface, nothing will happen due to underlying complement activation. But if you do have PNH cells which do not lack the complement regulatory proteins on the surface, when you have complement activation, this leads on to hemolysis of the red cells and subsequently all the complications which are related to PNH. And we know that complement is part of our innate humoral immune system, but it is not. It was supposed to be named. It was named complement because it was complementing the role of the antibody. but we know it doesn't sit in a box because it interacts with the other components of the complement system, including working as for opsonization, natural adjuvant to the acquired cell-mediated immunity as well. And I always explain complement as like a domino, which with three pathways: classical lectin and alternate pathway, starting at the top and leading on to the terminal pathway, which is the C5b9 or the membrane attack complex downstream, leading on to downstream effects. But the proximal components are also important because we know that the C3 convertases are important because of opsonization by C3b and IC3b, working on phagocytosis. C5a fragment important for phagocyte recruitment and also for chemotaxis. But the important terminal pathway effect is this membrane attack complex or target cell lysis. So this is always active in anyone, because complement is the first line of defense. And if you have complement activity all the time in the context of PNH, you will always have stable low-level hemolysis. So the other way of looking at it is the classification based on flow cytometry. So we know that type 1 cells means that they have a normal lifespan. But if you look at type 3 PNH clone, they completely lack the expression of CD55-59 in the context of red cells. And you can imagine these cells only living for about 8 to 10 days compared to 120 days. So you can imagine these trillions of red cells sitting in the circulation, which undergo constant hemolysis. So how would we come to a diagnostic pathway for PNH? How do we investigate somebody, and how do we have a clinical suspicion? So these are three broader categories of marrow failures, unexplained cytopenia, thrombosis, or Coombs negative hemolytic anemia. But if you look at slightly in a broader context, then sometimes you have to have suspicion, both with clinical symptoms. Some of the core symptoms are indicated here. And a few things I would want to indicate is that dark urine or hemoglobinuria is completely different to hematuria. We were just looking at our data of patients at King's with PNH, because we've got around 350 patients with PNH, with around 120 patients on treatment with anti-complement therapy. We looked at it and we found that there were a number of patients whose first port of call for their dark urine has been urologists. And sometimes it is simple, but people have not differentiated hematuria with intact red cells from hemoglobinuria, which is live cells. And some of these symptoms are quite typical for intravascular hemolysis, like esophageal spasm, dysphagia, abdominal pain. But important also to look at very, very subtle signs, like the gentleman which I presented with a high LDH. Sometimes low haptoglobulin can be an isolated thing, or an isolated hyperbilirubinemia or reticulocytosis can sometimes indicate that we need to check. And it can be a challenging condition to diagnose because of the myriad of clinical symptoms being very non-specific, because you could have these symptoms or signs in any type of diseases, but some of them can be significantly life-threatening or more common in patients with PNH, including thrombosis and abdominal pain, fatigue, and also renal dysfunction in this context as well. So this is another way of putting it, with different incidence rate as seen in it. And still we do see delays in the diagnosis, can be up to 10 years. The longest patient I've seen in our service at King's is a lady who had significant hepatic microthrombosis, like a sinusoidal obstructive veno-occlusive disease, and had to have a liver transplant done. And we only picked up that the underlying etiology for her liver dysfunction and liver transplant was an underlying PNH, which only came to light 15 years after she's had her transplant. So again, saying these can be very challenging to diagnose as well. So we know that with complement activation, hemolysis happens, and the destroyed red cells obviously lead on to anemia. But nature has left the hemoglobin protected very nicely within the red cells and not to be free. So free hemoglobin is an extremely good mopper of nitric oxide scavenger, so thereby leading on to vasoconstriction, hypertension, and thrombus formation. We should never forget that PNH is not just a red cell disease, it's a stem cell disease. So the platelets, which are byproduct of the mutated stem cells, will also lack GPI anchors, and this can lead on to activation, aggregation, and consumption. And some of the molecules are GPI anchor linked, like UPA, which can lead to impaired fibrinolysis. And downstream, there will always be endothelial activation, tissue factor initiation as well. So this is another way of putting this, showing that uncontrolled complement activation leads to intravascular hemolysis and thereby all the life-threatening complications, including thrombosis and other complications. So again, thrombosis in patients with PNH is extremely multifactorial. And it's mainly mediated by complement dysregulation, but not exclusively intravascular hemolysis, because we have to also think, like what I said before, some of the factors could be due to leukocyte activation, endothelial activation, and we touched upon the platelet activation. But it is very, very important in these scenarios to make sure you do not miss PNH. Because thrombosis in the context of PNH, either diagnosed or undiagnosed, is associated with a significant risk of death and early mortality from these two data sets as well. And not only is the thrombosis venous, there will be arterial thrombosis seen in these conditions as well. And we've got a couple of patients with coronary arterial occlusion who did not have any atherosclerotic heart disease at all, but isolated thrombotic manifestation of a PNH as well. We know these are all rare, but it's important to keep an eye out for this. And it's also important that in context of thrombosis without anemia or cytopenia, the chance of picking up PNH clones is low. But if you have a thrombosis with any degree of cytopenia, the chances that you could potentially pick up clinically significant PNH clones could be increased. The one thing I always tell all trainees and other people is PNH, unlike other rare diseases, has got a flow cytometry or a test which is extremely sensitive and specific. So never think too much about wanting to do a PNH test or not. If there is even a slightest suspicion, do a PNH test, and if it is negative, you can move along to the next stage of your investigations. And I always like to show this slide as well. As you can see, the things which are quite common, like antithrombin deficiency, protein S, the relative risk of getting a thrombosis is extremely low. But if you look at PNH, the relative risk of getting a thrombosis is about 60-fold higher. So again, saying if you have a PNH, there is a significant chance that these patients could be at a thrombotic risk, and so thereby it's important to pick these things up as well. One other way of classification of PNH before we move on to the underlying bone marrow failure and the treatment of PNH is this very old classification, but it also helps to keep patients into different types of boxes, which helps us to understand the management of this condition, where we showed before that the classical PNH do not have significant degree of overt bone marrow abnormality, i.e. cytopenias, while the majority of patients do have a PNH in the setting of another bone marrow disorder, mostly aplastic anemia and rarely myelodysplastic syndrome, but also subclinical PNH, very common in the context of aplastic anemia. So if you look at patients with PNH, there will be a degree of cytopenia in a number of patients as well, not just anemia, but also thrombocytopenia and other features as well. So we know in the context of aplastic anemia, your stem cells are under an immune-mediated attack that leads to contraction of stem cells, and you essentially get aplastic anemia. But and as shown by elegant work in the past as well. So what is aplastic anemia has got to do with PNH, and where do these two diseases cross over? So we know that normal stem cells have got number of GPI anchor and number of other transmembrane molecules on them. And when you have a PNH stem cell, They just lack the red blob, which is the GPA anchor protein. And this is, we know it's due to the mutation. But we know that in the context of aplastic anemia, there is a selective immune-mediated attack. So the question is, does that immune-mediated attack spare the PNH cell? So the other way of looking at it is, if you look at a bone marrow, and this is normal stem cells, if there is one PNH type of stem cell, and if the immune dysfunction attack, and there is a persistent immune pressure, this will lead on to expansion, a progressive expansion of the PNH chemopoiesis. And why do I say that we can pick up PNH cells in everybody? It is likely because this is a very old data, but essentially saying that even in healthy people, these are healthy blood donors, you can pick up PNH type phenotype cells or GPA anchor negative granulocytes in one cell up to 50 cells per million as well. Again, indicating that there is a selective advantage of this. And we know in about 40 to 50% of aplastic anemia patients, you do pick up PNH clone. So there is this relationship between aplastic anemia and PNH, not just related to the size of the PNH clone and the degree of hemolysis, but you do have a number of patients who sit in the middle of the spectrum with the degree of cytopenia, with the degree of hemolysis, with a moderate PNH clone as well. So this is the data from the King's group, which is published a couple of months back, where we looked at 3,085 patients who have had a PNH clones done over a period of 20 years. So this was a big, large effort trying to collect this data. And we found that you do see small PNH clones in a proportion of patients in around 5% of cases, and very small clones in about 10% of these 3,085 cases. And about 20% of MDS patients do have clones, PNH clones, and around 60% aplastic anemia. And this is the distribution and the spectrum in this, in the neutrophil clone size. And it seems to be, not surprisingly, PNH patients have got a large clone, aplastic anemia patients somewhere in the middle, and MDS patients. But more importantly, we wanted to look at their survival prospects. And it seems to be that even in this cohort, large cohort, the presence or absence of PNH clone was able to segregate the cumulative overall survival in the context of both MDS and aplastic, and also in the global cohort as well. And one more important thing in the context of bone marrow failure is we want to definitely make sure that these patients continue to be monitored for their PNH clone over a period of time. As you can see in this patient, the PNH clone expanded over a period of time. So again, this is in the BSH, or British Journal of Hematology, aplastic anemia guidelines, where we say that PNH clones should be tested at every 6 months in patients with aplastic anemia. If they're negative, if they're positive, then they need to be monitored at every 3-monthly intervals. And sometimes I show this slide because this is a slide courtesy of Professor Lucia Lisato and Professor Hillman, again indicating this is a very old slide, as you can see, from 1987. So this is a patient with aplastic anemia whose blood count starts to get better, and the transfusions start to reduce, and the hamsters becoming positive. So that's why provocatively we say, can the onset of PNH cure aplastic anemia? But it doesn't happen in all the scenarios as well. So now shifting gears for the next 15-20 minutes to look at treatment for PNH. So the first question is, why do PNH patients need treatment? Obviously, we know to prevent end organ damage like thrombosis, prevent their transfusion. The question is, who needs treatment and what stage? And currently at the moment, the question is, what is the appropriate first-line treatment? And if we have to also take into consideration availability of C5 inhibitors as well. As we know, although eculizumab is approved, Soliris is approved, there is only about 40 or 45 countries who do have reasonable free access to treatment. So although we always say transplant shouldn't be considered prior to C5 inhibition in the context of PNH, it's also a question we need to discuss in countries where the access to C5 inhibitors and clinical trials are not very readily available, and also monitoring of the treatment during the disease course as well. So this is historical treatment options in the context of PNH. As you could see, steroids, which is still used in a number of countries, do have limitations because steroids do work in PNH, but the problem is you cannot keep a bigger dose of steroids going for a long period of time. There was sort of myth around using iron and folic acid, but we should use it. It will not worsen the hemolysis, although there has been old data to show this. Thrombosis, I've not used thrombolytics in PNH patients with acute thrombosis in the context of C5 inhibition era. We still use warfarin, and there is some data evolving for the use of direct oral anticoagulants as a primary prophylaxis in the context of a large PNH clone. But unfortunately, there will not be any trials around to look at it. And I always worry about the skepticism because the DOACs turned out to be negative in the context of antiphospholipid syndrome. And we know PNH is an even more vicious thrombotic conditions and the underlying bone marrow failure. So this is the data why we still use primary prophylaxis in people with large PNH clone, i.e. granulocyte clone more than 50%. And this data is nearly 20 years old, but still holds true. We still do use warfarin prophylaxis or in context of large PNH clone, but we know that despite anticoagulation, PNH patients have got an elevated risk of thrombosis. So we need to, so I think if you look at the categories of PNH, like what I mentioned to you before, so the classical PNH, we would usually treat them with a C5 inhibitor. If there is inadequate response, we will consider all these things. But PNH with another specific bone marrow disorder, the focus should be on the underlying bone marrow failure. So if I take through the data for bone marrow transplantation very quickly, and then we'll come on to the anti-complement therapies available. So this is the EBMT data, which is now nearly 10 years old, published in Hematologica, looking at a large cohort of 211 patients who had a transplant for PNH, and this is the segregation. So interestingly, if a PNH patient has got thrombotic manifestation and those patients go for a transplant, their survival seems to be poor, but it seems to be reasonable in the context of recurrent hemolysis or an underlying bone marrow failure. And this is the hazard race indicated, but still, obviously, we all are aware that the transplant GVHD complications and other infectious complications are still present even in this era. So what they did in this data was they compared the transplanted patients, 24 patients, with patients who did not have transplant, and found that in this setting, at least in patients who have thrombosis associated with PNH, it better seems to be better leave them not consider them for transplant, but treat them with anti-complement therapies seems to be better in this context than not. So what we looked at is we looked at whether we can use eculizumab in patients with PNH with severe aplastic anemia prior to hematopoietic stem cell transplant. And this is a simple Kaplan-Meier showing that in the context of PNH, who need eculizumab for their underlying PNH, but unfortunately their bone marrow failure takes them towards a transplant. We found that the median overall survival is around 70-75% at 2 years, with a median follow-up of 2 years. The main transplant-related mortality was due to infections and a couple of cases of veno-occlusive disease as well. Again, saying although transplant is an option in patients where there is access to the drug is not there, we need to take it with an important consideration when they have thrombosis or they have other factors which increases their non-relapse mortality and transplant-related mortality as well. So where does complement inhibition come? So where the rationale for blocking C5 is due to uncontrolled complement activation, and we know eculizumab binds with high affinity to C5, so it's the terminal complement cascade which is totally blocked, and the proximal functions are left intact. LDH is an extremely good marker for intravascular hemolysis, as we know. And in this TRIUMPH, which is a placebo and eculizumab controlled study, you could see that the LDH plummeted down to more or less normal levels or less than 1.5 times upper limit in 90% of cases within 1 month of initiation of treatment. and the placebo patients did the same when they crossed over. And this has been shown in a number of studies many years back now, indicating that this drug, the C5 inhibition, is fantastic in the context of PNH. These are some of the indications for treatment in UK. So these are transfusion dependent or independent. If they're independent of transfusions, we look at these factors. Have they got thrombosis? Is there hemolysis leading to end organ damage, pregnancy, or hemolytic PNH with any of these symptoms associated, and with agreement of the joint MDT and some of the exceptional cases as well. So this is the EMA approval 4 or 5 years back now, where they use some of the factors which we've been using for. And what's the clinical efficacy of eculizumab in PNH? It works very well, reduces hemolysis, stops transfusion in 2/3 of patients, more or less prevents thrombosis in this group of patients, improves fatigue, and also prevents some of the renal complications. And we know survival has significantly improved compared to the historical population. As you can see, pre-eculizumab era, 30% of patients died within 5 years of diagnosis, while we know now that some of the patients treated with eculizumab have a similar survival to age and sex-matched controls as well. And this is the French data, which was also published 4 or 5 years, showing the same thing, comparing eculizumab versus controls beyond 1985, and the historical controls going beyond as well. So these are some of the data, which is 2 years old now, treated in UK. So UK has got a population, at least England has got a population of around 53-55 million. So these are the number of patients we've treated and number of patients who had to stop treatment as well, because we know there are patients who could stop treatment because of this phenomenon called clonal remission. So that's why it's important to monitor for the PNH clones during the course of the disease as well. This is one example of a patient treated for a few years, the clone size going down. Just for generally, treatment, anti-complement therapy does not induce the clone size to go down. It is the natural phenomenon seen in this disease. So it's nothing to do with the treatment, but it's just the natural phenomenon that the PNH clone starts to go down, and we had stopped treatment in these patients. Obviously, meningitis is a big risk, because there is about 1,000-fold increase in the risk of meningococcal meningitis when patients are treated with any C5 inhibitor. So we tend to use prophylactic penicillin long-term, because most of these Neisseria meningitis is from the throat, from the nasopharyngeal carriage. We vaccinate them against A, C, W, and Y, and also serotype B, and they contact our patients. And this is some of the long-term safety data, both in pregnancy and also in meningococcal infection. As you can see, the mortality, there is a mortality associated with it. This doesn't mean that the rates are going down, but it's probably some degree of reporting and collection bias. But again, saying that the risk of meningitis is definitely there. And we showed some data of use of eculizumab in the context of PNH in pregnancy as well. So despite successful treatment with eculizumab and preventing the thrombotic complications, hemoglobin levels in patients on eculizumab do tend to remain at a lower level compared to normal individuals. And that could be due to a number of reasons as well. One of the phenomenon is called breakthrough hemolysis, which has been seen even in the early days of the pivotal trial, where prior to the 14-day window, what happens is the LDH starts to creep up over a period of time, and the trough level of the drug starts to go down as well. So there is less drug in the system pharmacokinetically, and also the LDH starts to go up. So, and this is manifesting with clinical symptoms as indicated there as well. So therefore, although it's not approved doses, we have a number of patients, up to 20% of patients on higher doses of eculizumab over a period of time since the survey started in 2004. The second phenomenon is something called extravascular hemolysis. So here, the complement pathway is now arranged horizontally rather than vertically, and you can see all the players there. And we know eculizumab binds to C5 and thereby prevents the terminal complement activation. But there is a very rare mutation in C5 which makes it resistant to eculizumab. But what happens is, although you're blocking the terminal complement pathway, the proximal amplification loop is extremely active and thereby leading on to C3d degraded products, including IC3b and C3dG deposited on the red cells. And these can be picked up by flow cytometry. But these cells should be removed from the circulation. And this is where the concept of extravascular hemolysis comes in, i.e., these cells are taken up by the liver and spleen or reticuloendothelial system, inducing a concept called extravascular hemolysis when patients are treated with C5 inhibition. And there are other reasons why patients could be still anemic in the context of being on C5 inhibitors, and some of the factors we've covered. But very important is also to make sure that this is not due to an underlying bone marrow failure or due to other reasons like chronic Budd-Chiari with hypersplenism, EPO deficiency, and also iron overload as well. And the question is, why do we need newer complement therapies? Because we know that we sometimes might need better control with no breakthroughs, and also can we prevent extravascular hemolysis, and there's also ability to work in all patient groups and safety. But it's also important for the cost and availability as well, because we need to have treatments which we can use access to all the patients around the world, and more anti-complement therapy drugs will bring down the prices, and also important for the role of biosimilar as well. But important also is we should not increase the risk of infections or less effective for thrombosis or underlying bone marrow failures. So in the last 5 to 7 minutes, I'll try to take you through what are the newer agents which are in clinical trials or approved, which in not obviously here, but approved in US and Europe, which could potentially help. So one of the compounds which we've done a number of clinical trials is this compound called ravulizumab, which is a high affinity anti-C5 monoclonal antibody. It's derived from eculizumab. It's also a C5 inhibitor. What it was done by 4 amino acid change in the tip of the antibody is that it enhances the receptor recycling, increases the half-life, and keeps the same favorable safety and tolerability profile as well. So it's essentially a recycling antibody. So instead of eculizumab being given every 2 weekly, you can give ravulizumab every 8 weekly. And this is the modifications which has indicated there here in the FC in the region as well. So again, showing that this is a development which is a high affinity anti-C5 antibody. So these are the 2 trials, 301 and 302 trials. This was in patients who never had complement inhibitor. This was in patients who had complement inhibitor. This is another way of putting it, showing in the primary, this was a non-inferiority trial. So this is given on day 1, day 15, and then every 8 weekly. So if you're comparing it, crosses this line. So it is not superior, but non-inferior. And similarly, in the context of patients who were treated with prior eculizumab, they were changed either to ravulizumab or to continued on eculizumab, and here the primary endpoint is percentage change in LDH, again showing non-inferiority as well. But the more important thing for me was looking at the serum free C5 level. In the context of ravulizumab, you do not see these fluctuations in the C5, complement C5 level. They're all very tightly below that limit, indicating that none of these patients reached above that 0.5 threshold. And most of the eculizumab patients at some point had this fluctuation. So having a better sustained and a complete inhibition of serum C5. Breakthrough hemolysis has been seen in this context as well, and there are different types of breakthrough, but the breakthrough related to low drug level or with a high C5 is not seen in the ravulizumab arm, but mostly associated with infections or other unrelated to infections as well. But the most important aspect here is the preference of the patient. So patients seem to prefer ravulizumab because it's 6 infusions in a year rather than 26 infusions in a year for eculizumab, and that helps them for planning their activities and also doing all other things, controlling fatigue and symptoms as well. So this drug has been shown to be non-inferior, but sort of safe, but sound to be very similar efficacy in the context of eculizumab, but less breakthrough and better tolerability as well. So a few other C5 inhibitors, or the drug called crovalimab, which is similar to ravulizumab, has got engineering of C5 so that it stays in, but different is it can be longer term, can be given subcutaneously every 4 weekly. This is the data from the preliminary phase 2 trial, where it showed that in the patients with treatment-naive patients and patients switching, there seems to be an increase in the hemoglobin and also stability of the reticulocyte count as well. A few other compounds for C5 inhibition. So this is a fascinating compound because this is an siRNA targeting C5. So it is conjugated with GalNAc and thereby does its job by knocking down the C5 with this drug, so it can stay in the system for a longer period of time. There were early trials, but it's making a comeback again with another compound. A few other compounds this is a drug called Coversin, which is a C5 inhibitor, which is given subcutaneously every day, self-administered by the patient. A fascinating compound because this was isolated from the deer ticks, because here you can see the ticks biting on the deer and secreting this compound, and the deers don't know that they are bleeding because their complement pathway is totally shut down by this, and thereby this compound is synthetically generated from this. And this is just an example of one patient, which was published a year back in British Journal of Hematology, showing its efficacy in a patient who had the mutation of C5 as well. And it comes in a self-injector pump as well. This is very important, biosimilars as well. So there are 3 biosimilars which are undergoing trials. One is ABP951, there is another SB12, and there is also biosimilar in Russia. So it is important because that will sort of help to bring the cost down and also be widely used in a number of other countries. So I did talk about C5 inhibition in the context of PNH, and this, you would think that this is a disease where there are very few patients, but because the way we work in England with only 2 centers treating PNH, we have all these trials which are in yellow or ongoing in King's, or patients are on the treatment, so indicating that number of compounds can be used in the context of C5 inhibition, and biosimilar is important. But if you switch gears and talk a bit about C3 inhibition, I'll touch upon a couple of compounds and end the talk. I'm happy to take questions after that. Is this drug which is called Pegasus or pegcetacoplan. It was just literally published 3 weeks back in New England Journal of Medicine. So this is, as you can see, the drug is sorry, not just apologies. I can't. Hope you can still see my screen because I'm just getting the Q&As on the top of my screen. Okay, I'll continue with this. So this is a drug where in patients with prior eculizumab, they were either continued onto pegcetacoplan or to continuation of eculizumab, and you could see that there is a mean change in the hemoglobin. This is another way of graphically representing it, showing that the difference in the hemoglobin between these 2 things. And also importantly, reducing the C3 loading, because you could see in the context of continuation of eculizumab, you still have loads of C3d deposition on the context of red cells, but when switching over to pegcetacoplan, the C3d loading was reduced, and this is shown by the type 2, type 3 PNH cells, red cells increasing, and also the C3d deposition. Yeah. And this is some of the side effects associated with it, fairly well tolerated, but there was sometimes related to diarrhea, and patients had to sometimes discontinue treatment as well due to some of the complications, predominantly some of them with the breakthrough hemolysis as well. And this is another phase 2 trial which is ongoing. So that's with broad C3 inhibitors. But there are also proximal C3 inhibitors, one of them being danicopan, the other one being iptacopan, which is LNP023. So they're all in phase 3 trials. Phase 2 trials have been published, again showing that blocking factor D, as in this context, or which we've shown in a couple of trials. This was published in Hematologica. So this is an oral compound given every three times a day, along as a single agent in patients not treated with PNH, indicating that the LDH going down and the hemoglobin improving as well. So we also had a trial for patients who were on eculizumab who are suboptimally controlled, and we used this drug in addition to eculizumab, and we were able to stop transfusions in this cohort of patients as well, while they were on both eculizumab and proximal inhibitors. So there are a number of other second-line therapies which are ongoing, either as a dual inhibition or as an add-on. But the question is, this spectrum of treatment in PNH is expanding extensively. So, so we know that there are a number of compounds there which are showing promise in phase 2 trials, and phase 3 trials are ongoing in the context of PNH. So this is some of the proposed algorithm for treatment. So if it's classical PNH, you will treat them with the complement therapy. If it's hemolytic with a high disease activity, then you would still consider them C5 inhibition. But if you have a combination of aplastic and PNH, then you could use different combinations of treatment as well. So I just did not touch upon this compound. This is a factor B inhibitor, which was published in Lancet Hematology last week, showing again addition of this compound called iptacopan in patients on eculizumab, reducing these transfusion or abolishing, because none of these 10 patients who were on the treatment needed blood transfusion. And if you look at it, 7 of the 10 patients were able to stop eculizumab as well. So this is an oral compound given twice a day as well. So the PNH service works in UK in a totally different way, because all the patients who live around London and the home counties, which is where I'm based on, serving a population of 23 million, will be treated at King's, while the other center, where Professor Peter Hillman is working with other colleagues, treat the other patients in the country. So that gives us ability to treat them in a uniform manner and in a coordinated manner as well. So I think to stop, I will say PNH is probably one of the most vicious acquired thrombophilic states in medicine. I did not say it. Somebody more clever said it, Professor Lucia Lusato. Eculizumab was never made for PNH, but it's been extremely useful in reducing a number of complications, and it's also extremely safe in pregnancy. Although it's not recommended, although it's not licensed in pregnancy, we all know that there is about 10 to 15% mortality and morbidity in pregnancy. So these patients should be treated during pregnancy as well, and postpartum period, to stop their complications. It's a nationally funded service, and we've seen significant quality of life improvements. Obviously, there is going to be unmet need with any drug, but not in the thrombotic setting, but in anemia and patients having some degree of hemolysis and rare genetic variants. And there are a number of newer compounds which are ongoing in clinical trials. But the question is, if we do see clonal regression in 5 to 15% of patients, should we think of aiming for a cure in this condition rather than just trying to treat these patients for a lifelong or a long-term treatment? So I think with that, I'll stop, and happy to take questions. I can see a number of questions coming up on Q&A, but I think I'll be happy to take questions if that's okay.
Excellent. Great talk, and very informative, very comprehensive. Thank you, Austin, for such a nice lecture. Yes, we have a number of questions, and well, I'll probably start with some of these questions and then come back to some others. So we have our first question here, and I think you addressed this. What about avacopan? I think it's one of the complement inhibitors.
Yeah, so avacopan is a slightly different agent. It's an C5a inhibitor, which has recently been licensed predominantly in lupus-related nephritis and a particular type of glomerulopathy as well. It will mechanistically, it might not work in the context of PNH because this will be mainly for the C5a on the chemotaxis and in the neutrophil network as well. So unlikely to work in the setting of PNH, although I'm not an expert in that area at all, but it is an interesting compound.
Right. Would you continue anticoagulation despite lifelong eculizumab?
Okay, so that's a very important practical question. So if a patient has already got a thrombosis and you start them on anticomplement therapy or eculizumab, i.e. as a secondary prophylaxis, we tend to continue those patients on secondary prophylaxis along with eculizumab for a long term, unless they develop bleeding complications or thrombocytopenia or other things. But if you start eculizumab as if you stop anticoagulation as primary prophylaxis and then put them on eculizumab, you could safely stop the primary prophylaxis with warfarin or Davax within 3 to 6 months of treatment.
Right, right. Okay, and a question from Benjamin. So would you consider allo-BMT or increase the dose of eculizumab as a first step when breakthrough hemolysis happens? So PNH clone is increasing every year in a young male, age 26. He never had thrombosis.
Yeah. So this is a very classic situation where you have an young chap who is getting episodes of breakthrough hemolysis. So the first thing we would do is most likely this breakthrough hemolysis is due to pharmacokinetics, i.e. the dose of eculizumab might not be sufficient. So the SMPC says that you can give it plus or minus 12 days as well. So plus or minus 2 days beyond the 14. But what we tend to do is we tend to increase the dose of eculizumab. So that's probably what I would do as a first measure. And the second thing is usually when patients are on PNH treatment, the clone size usually tends to increase, predominantly the red cell clone, because you're stopping these red cells from hemolyzing. So the red cell clone will likely to increase. It is always a very tricky question for a 20 or a 25-year-old patient who, are you balancing between committing them to a lifelong treatment versus a treatment, a BMT, which could have a success in 70%, maybe 80%, but still, unfortunately, that 20% mortality, morbidity. So I would, if there is availability and access for anticomplement therapy, I will keep them on it and try them in a higher dose to control the breakthrough hemolysis.
Right, and that's also covers the answer to the next question. I mean, is the cost? I mean, being costly. I mean, would that make you lean towards stem cell transplant in certain cases? From Dr. Bayroti, I think definitely. I mean, the access, has a role. However, I mean, if you can access the eculizumab or other medications versus stem cell transplant, which also carries in this particular disease, a high mortality rate, as you have shown in certain indications, I guess. You might comment on this, Dr. Austin.
Yeah, this is always a very, very difficult question, is it? There's a balance between cost versus lifelong treatment or long-term treatment versus a transplantation procedure, which we all know we will be keen because to consider for these group of patients to give them a drug-free role after a period of time. Because I usually use a couple of examples. I've got two patients who are 20s and 30s who got large PNH clone on eculizumab. Both of them have got a identical twin who don't have PNH. So the temptation is for me to consider transplantation for them, but they're doing so well on the anticomplement therapy. Even if there is a risk of 5 to 10% or 20% mortality and morbidity, I'll be kicking myself, why did I transplant? So I would say it is mostly driven by the local practices of access to the drugs and other things. But as I showed, in hemolytic PNH patients rather than thrombotic patients, the survival seems to be better compared to thrombotic patients, but still not 100%. So unfortunately, so if there is access is not a big issue, I would consider anti-complement therapy rather than stem cell transplant, although I'm a big advocate for transplant.
Yeah. So it depends on the manifestation, I would say. And if it's aplastic anemia, you would probably lean towards the bone marrow transplant.
100%. If there is no question, if there is a patient who's got concurrent marrow failure and PNH, even though they're hemolyzing, I would say likely that they will benefit, their benefit from transplantation would be better, because you kill two things in one, or technically it's only one disease, bone marrow disease, manifesting as cytopenia. So concurrent bone marrow failure, cytopenia should be given priority for treatment, and the algorithm should be based upon that treatment.
Right. The next question is also another interesting question. And so is there any data about the use of anti-complement in perioperative setting for patient? I don't know how they discovered the clone. So 60% clone, otherwise asymptomatic and no thrombosis.
Yeah. So I will answer this in a couple of different ways. Yeah. One is in patients who are on anti-complement therapy, any acute scenarios like stress, pregnancy, surgery, trauma leads to complement activation, and we would give them a dose of eculizumab to cover the surgery. Here, the scenario is different. This is not a patient who is on treatment. Presumably because although 60% clone, this patient is asymptomatic, has got a compensated hemoglobin. But if the LDH is anything more than 1.5 to 2 times upper limit of normal, I'd be extremely careful in covering these patients perioperatively with anti-complement therapy. And the other example is, this is not dissimilar to pregnancy. So you've got somebody who's stable generally, but once they get pregnancy or states of complement activation, you would want to cover them during that period, both with anti-complement therapy and anticoagulation. The third way I will say is, we have a number of patients in our center who got 90% clone, LDH of 5 to 10 times upper limit of normal, but extremely well compensated, who are eligible for treatment, but they don't want treatment, but they've gone on for a number of years without getting any thrombosis. So it's a balance between patients and discussion as well.
Right. Would you keep screening? You mentioned that actually screening for the clone, anaplastic anemia and others. And how would that also influence your management?
Yeah, so as I said, we tend to monitor the PNH clone in the context of aplastic anemia as well. So just the presence of PNH clones per se in a patient with aplastic anemia will totally not influence my management, but I would strongly consider them for immunosuppressive therapy, because that data seems to hold true even in this era, showing that presence of PNH clone indicates that this is likely to be an immune-mediated bone marrow failure rather than a constitutional bone marrow failure. And we would more advocate towards immunosuppressive therapy if their phenotype is bone marrow failure.
And would you keep them on eculizumab as well?
Yeah, so we have a couple of patients. So that's always a difficulty. So we have some patients where we have first gone in with anti-complement therapy, given them 3 months to see if they benefit. And if they didn't benefit, we then give them ATG cyclosporin, but we'll keep them on it. Some patients we've gone in with both. We've given them eculizumab and single agent cyclosporin. Some patients we've given them ATG cyclosporin, monitored them, and over a period of time, we find that they start hemolyzing and then treated them with eculizumab. So it all depends upon individual patient-to-patient scenario.
Yes. Would you also recommend keeping them in eculizumab while undergoing stem cell transplantation?
Yeah, so that data is what I showed. I rushed through that data. So we're just going to publish that data where we have around 26 patients where we have given them eculizumab because they had a large PNH clone associated with hemolysis, but also had an underlying bone marrow failure. So we used eculizumab during the peri-transplant period. We tend to stop it on the date of starting of conditioning. and we don't give them post-stem cell infusion, and we check the PNH clone at the time of engraftment. And if the PNH clone has disappeared, and if the LDH is normal, then we would not give any further dose of eculizumab.
Okay. So next question is, this is a patient with thrombosis, unprovoked thrombosis. However, he only has PNH clone, small PNH clone. So would you consider him as a PNH?
I don't think so. It's an important thing, because we do see patients where we screen for thrombosis and find PNH clone of 0.01%. What does that mean? It doesn't mean anything if they do not have a high LDH or a high no indicators of hemolysis. I would continue to monitor them, but I don't think so. This patient, which Dr. Mohammed Eid is indicating, you can't class them as PNH. I think there is probably some other reason for an unprovoked thrombosis. I'll keep checking their PNH clone just to make sure it's not going up. But at this stage, I don't think so there is any strong recommendation personally to think of anti-complement therapy.
When would you consider screening for genetic mutation, PIG-A and others, maybe?
No, we do not use PIG-A mutations for screening at all, because the flow cytometry is such a sensitive and specific tool in the context of PNH that you do not need it. It is so easy, done on peripheral blood, you can repeat it. It's so good that we don't screen PIG-A mutations. We only do it in our research laboratory.
Right. All right, Dr. Bairuti, question here. So are there any other long-term complications beside the infection? And yes.
No. So the data which I quickly skimmed through on the pregnancy and the long-term meningococcal meningitis published in British Journal of Hematology, no is the answer. So the only particular thing is Neisseria meningitidis. I've seen one patient of Neisseria gonorrhea, but we don't see other infectious complications, touch wood, at all. And the first patient in our center is the first patient treated in the pivotal trial in 2002. So we monitored her for 20 years, and we don't see other infectious complications. I don't know whether it will be the same in the era of C3 inhibition. I don't know, but the early data seems to be similar.
Right. All right, because of the time, we'll have one more question. How does this apply to pediatric population?
Yeah, so pediatrics, there is a couple of studies which are ongoing, but one of the more advanced one is ravulizumab, which is now being tested in the pediatric setting, and the data is likely to be presented in EHA in June, a smaller number of patients, but other drugs are being tested in the setting of pediatrics as well.
Right. Okay, well, there are actually a few questions, but I think we're running out of time. Thank you again for our attendees and for posting these questions. We have to move on, I guess, and be on time to finish this interesting talk and very informative, actually. Thank you, Austin, for such a nice talk. And very, by the way, very illustrative and informative slides.
Thank you. Thank you. Thank you so much, and happy Ramadan, everyone, as well.
Thank you. I just wanted to remind our attendees about our next week to be in Ramadan, and we will move the time to 10 p.m. instead of 9 p.m. Because of Ramadan timing. So our next webinar will be Diagnostic Approach of Bone Marrow Failure Syndrome by Lucy Godley. So looking forward to see you all in a week. Again, thank you, everybody, and have a good night and goodbye. Thank you, Biologics, for sponsoring this event. Thank you.
Bye.